the Society of Otolaryngologists of Nepal to this wonderful webinar supported by CIPLA. I'd like to introduce today's speaker, Dr. Dipesh Sakhe, registrar in the Department of ENT and Head and Neck in Civil Service Hospital, Government of Nepal since 2013. Dr. Dipesh and Dr. Arun Kesi, they are considered as a pioneer of endoscopic sinus surgery in Nepal, which is carried away by Dr. Dipesh right now. Dr. Dipesh is a fellow of International Working Group of Endoscopic Sinus Surgery, and it is a very prestigious group. And he is only one of such a member representing from Southeast Asia. Dr. Dipesh, he started his medical education from Philippines, where he started to get awards from the first year of his academic career. Every year, I can see he's in CV, he is honored with one or other awards. And he has, at the end of his training program, he was awarded a silver medal for scoring the second highest in his medical school. Then Dr. Dipesh, he completed his ENT and head and neck training in 2013, where he was honored with the 2 gold medal for securing the highest score in ENT and head and neck examination conducted by Tribhuvan University in 2013. Dr. Dipesh has got more than 10 publications in his cap, and he has been awarded with various awards in various international and national workshops or in national and international conference and seminar. And Dr. Dipesh, he is also trained from house. He also is trained from a House Air Institute in California, USA. So we are so privileged to have him today with a fundamental of total endoscopic sinus surgery. Dr. Dipesh.
Thank you, Dr. Yogesh. I hope you can hear my voice.
First
of all, I would like to thank Seoul, Nepal for providing me with this opportunity to talk on something that I've been doing for a couple of years. And I still think I'm not so much perfect in this field. I'm just learning phase. Second, I would like to thank CIPLA for this platform that has been given for us to talk on. So my topic today is fundamentals of total endoscopic ear surgery. This topic is based on eminence, which is backed up by evidence, which means we will talk more on the practical aspect or my own personal experience, which is basically backed by evidence. And this slide is basically showing the different topics that will be covered in this conference. And coming to terminology, total endoscopic ear surgery, which is in a short form is termed as TEES, is also called as transcanal endoscopic ear surgery, total endoscopic ear surgery, or single-handed endoscopic ear surgery. And when I mean by total endoscopic ear surgery, it means that I am using only endoscope for the whole completion of the surgery. The new concept now is the functional endoscopic ear surgery. Functional endoscopic ear surgery, meaning now it is same like a functional endoscopic sinus surgery. I will explain it later. Primary endoscopic ear surgery is basically same as microscopic assisted endoscopic ear surgery. It means you use endoscope as a primary tool and you get the assistance of microscope. Secondary endoscopic ear surgery is you get the assistance of endoscope where you start with the microscope. Coming to brief history, as we know that microscope is still a gold standard in otology, and it was developed by Swedish otologist Carl Olof Nyland in 1921, but it was not famous because it was monocular, and then later a binocular was developed by Holmgren, but after 30 years only a JAIS came, and that's the one we are using now. Hopkins rod endoscope was developed by Harold Hopkins in 1966. That was 10 years after the development of microscope. And 1 year later, Murr was starting to do the study on that. But then from 1967 to 1992, you can see there's a huge gap where endoscope was used for endoscopic ear surgery, which is used as a secondary basis, and then a lot of studies was published on that. Until in 1992, El Guindi from Egypt was the first to publish the total endoscopic ear surgery, where endoscope was used as a primary source. And father of endoscopic ear surgery is considered as Tarabichi because he published a lot of publication in 1997 solely based on different procedures that you can do solely by using endoscopic ear surgery. And here in this, and later on, this international working group in endoscopic ear surgery was formed. Right now, the president is here. You can see in this picture is Professor Badr Eldain is from Egypt, and Professor Nirmal Patel is from Sydney, and Professor Shizi Kakehata, Professor Macchioni. These are all the giants now for the endoscopic ear surgery, and it is so honor and privilege for me that I could learn a lot from these giants in this field. So what are the changes that are brought by total endoscopic ear surgery? There are a lot of changes that are brought by total endoscopic surgery. That includes new anatomy, there are new nomenclatures, new classifications, and new concept of disease pathogenesis. And so the new concept of treatment. So this is basically a classification of Massachusetts Eye and Ear Infirmary, which it says that class 0 is you use only the operative microscope, and class 3 is you use the endoscope only. And in between is where you exchange the endoscope and microscope. New anatomy, it will be long if I will explain all these anatomy, so I'll just give you a brief. Now, the new anatomy includes different types of ponticulus, different types of classification of sinus tympani, different types of round window niche, different types of supratuberous recess, sinus subtympanicus, and all that. Here in this picture, you can see the bridge of a bone, which is in between the promontory and the pyramidal process. This bone, which is called as ponticulus, can have a bridge, which is separating with the posterior sinus, like here, or it can have a gap, like in type C. And these both pictures were taken from the surgery that we did in Civil Service Hospital. This is again another nomenclature for sinus tympani. This is a very wonderful book that you can get. It's a manual which was published by all the pioneers of International Working Group in Endoscopic Ear Surgery. It's a very good book, and I would recommend everyone to go through this before doing endoscopic ear surgery. Coming about the pathogenesis, what's the new thing in endoscopic ear surgery? They brought the concept of mucosal fold and the epitympanic diaphragm and the ventilation routes. This was actually explained 100 years back, but it was only in 1945 the Lemoine and Chateliers had explained it, and later it was further elaborated by Palva, and then the latest one is by Professor Macchioni, who explained a lot in this part using an endoscope as a tool to give us different types of anatomy. You cannot see a tensor fold at all using a microscope. For that, either you have to do a cadaveric dissection, but in live surgery, you cannot see that. It's only by the endoscope you can see the tensor fold and the supratuberous recess, and that's how came the new concept. Now, the concept is the epitympanum and the mesotympanum are completely separated by what is called as epitympanic diaphragm, which forms a floor. And this epitympanic diaphragm is made up of 3 ligamental ligaments and 2 fold and 1 posterior incudal ligament. So how the ventilation occurs is the air goes from eustachian tube, it passes through either anterior isthmus or posterior isthmus, which is also known as proctor's isthmus or proctor's posterior isthmus. And the anterior is the main part which lies between the processory cochleariformis and the stapes. So here in this picture, you can see the ossicles are already removed, and this main part, the dark one, the big arrow one, is the main ventilation pathway, and the axillary are the posterior isthmus and the tensor fold defect. The defect in tensor fold is seen only in 25% of the cases only. How does the disease occur? Disease occur is because there's a hampering of ventilation. If there's a closing of this isthmus, so the disease is developed in epitympanic region. And the middle ear pressure is regulated either by the eustachian tube or by the buffer system. Now the mastoid cavity is considered as a buffer system because As you know that if there's a defect in ventilation, you get a sclerotic type of mastoid, or if there's a defect, if there's a patency in the ventilation, then you get well pneumatized kind of mastoid. So there came a concept of selective epitympanic dysventilation. Is basically there's a problem with ventilation pathway, and only the epitympanum is developed. And the new concept of functional endoscopic ear surgery is telling us that to open this ventilation pathway to get normal results and to get better results. And there was a concept of doing cortical mastectomy for the chronic otitis media mucosal. If there's a chronic discharge, I think this concept is now changing because of the concept of functional endoscopic ear surgery. So you can see the epitympanic diaphragm can have a three kind of attic ventilation, which is called as type A, B, or C. A is basically there's a complete blockage from epitympanum to mesotympanum. The diaphragm is closed, but the ossicles are intact. Type B is there's a defect in tensor fold, but there's a ventricle fold, vertical fold is present. So the posterior epitympanum is still affected. However, the anterior aeration is still present. And the third one is a type C kind of aeration where there's epidermization of attic. All the ossicles are gone, but the ossicles in the mesotympanum is still present. So here, these are the both cases that we encountered in civil service hospital. You can see there's no ossicles at all in the attic area in the both picture. I'll show you in a little while the video on how we did a surgery on that. Okay, so why I always tell patient, or why I love endoscopic ear surgery so much is, before saying that, I would like to tell a statement that we are not microscopic or endoscopic ear surgeon. We are ear surgeon. So we should not say that, oh, we'll do only endoscopic ear surgery or microscopic ear surgery, but we should be able to do both in that. This statement is, you will hear this statement in any course you go, either you go for international conference or national conference or all that. And it is my honor for now to tell that I am the only one and the first to become a member of the international working group in endoscopic ear surgery. You can see there's only very few dots, and there's only one that can be seen in Nepal. And then it's very, I feel so honored to be a part of this group. And in every surgery, there's always the three stages that happens. It's just same like the endoscopic sinus surgery, where there was a time that people were not saying that endoscopic sinus surgery is good. So it's the same like there were lots of controversies in the beginning when the endoscope was introduced solely as the tool for doing ear surgery. So the three stages were, first, it was ridiculed, saying it was not liked. Second, it was violently opposed. And third, it was gradually accepted. So we are now in a third stage of this endoscopic ear surgery. So when I mean by wide angle view, this is the #1 factor why I like endoscopic ear surgery. Why? Look at this picture. You can see everything in this one frame. You can see the whole bridge in one frame. Look at this picture in the second. You can see everyone in one frame. It makes easy. You can see here all the mountains in one frame. Here you can see all the sea and all the beaches and all the areas you can see is cleared. If you notice or not, this is Dr. Dipendra Gautam and this is Dr. Sanjay. This is the picture that we took when we were in Hong Kong for the training. So wide angle view, it's like a panoramic picture that you take. That's the #1 reason. See, in this picture, you can see everything in one frame. What are the other benefits of endoscopic ear surgery? You can go into nooks and corner. There are times that you cannot see at all using a microscope, such like sinus tympani or retrotympanum, hypotympanum, anterior epitympanum. These are all things that are seen easily with the endoscope. And the high definition and the magnification is just so superb at present. But in the beginning, when the endoscope was used, look at the picture here. It's so blurry, you cannot make it out anything at all. And then this came, it's like a high definition. So the Professor Nirmal Patel has stated the magnification is such that you can even see red blood cell cluster traveling through capillaries in the middle ear. So let me show you a video on that. I hope the video is playing. I'm not sure because I cannot see if the audience is seeing or not.
Yeah, we can see it. We can see the patient is playing nicely, smoothly.
So here you can see, this is the wide angle view that you can see. And then here, look at the incunostapital joint and the blood vessel around it. Do you see a blood vessel with the black dots? It's moving. Do you see? I'm not sure if you can see or not, but in my screen I can see it. I don't know if you can see it in mobile. That's the beauty of endoscopic ear surgery. You can even see red blood cells in that. How about the other benefit of wide angle view? See, here you can see round window niche, you can see the stapes, you can see the hypotympanum, you can see the eustachian tube opening, and you can easily see the defect in hypotympanum. That's the beauty of an endoscope. So why tease? What are the other benefits of endoscopic ear surgery? And when I say about the surgeon view meaning that whatever a surgeon is seeing is what the other people are seeing also. So here you can see one of our colleagues, Dr. Nirmala, is operating. In the screen, you can see what he sees is everyone is seeing. Here you can see the two surgeons are operating. He's Dr. Ramesh Paraduli and he's Dr. Anurag Srivastav. And they and I was first year at that time. And that's here you can see that the picture that a surgeon is seeing is not always often the time that the assistant is seeing. And when you use a microscope, it feels like you are working very far. Unlike in endoscope, you feel like you're working very close. What are the other benefits? Obviously, you are doing total endoscopic ear surgery through transcanal approach, so there's no scarring, there's no incision, there's no bandaging. The patient is very happy after the surgery. Local anesthesia, you can just finish the myeloplasty in 2 to 3 milliliter, and that saves a lot of money. And that and for us, because we are a poor country and we do lots of health camp, I think in the endoscopic ear surgery is perfect tool. If you are going to a health camp, you can just take a monitor, laptop, and you can even do a surgery in that. Why not tease then? What are the not benefit? What are the disadvantages of endoscopic ear surgery? What are the fact that people don't like about it? Is number one is one hand surgery. They always say that you have only got one hand, so it gets difficult to learn. But since we do permeatal surgery a lot, I think with practice this is overcome. How about the crowding of instrument? Too much instrument is difficult to negotiate inside a small canal, but that also with the practice and practice it goes away. How about the trauma when the patient moves and then you get a trauma by the endoscope? So in our cases of more than 700 cases, this is not seen. And then that has never happened. And that supports in the literature also. Lots of surgeons didn't experience that. How about the thermal injury that is caused by the tip of the endoscope? Thermal injury, that was the speculation that was given way back before, but then this is already now negated by lots of articles on that. And there are methods how to decrease the thermal injury on that. I'll tell you later on in my tips. And the main part is the bleeding. Bleeding is the one that makes people frustrated when they do for this endoscopic ear surgery. So the most difficult part when you do endoscopic ear surgery is raising the flap, because while you raise the flap, that's the time you get lots of bleeding. How about the learning curve? So what's the learning curve in endoscopic ear surgery? Look at the difference between the microscope and the endoscope. Learning curve of endoscope is way, way, way more than microscope. But once you reach in the hill, you pick up, which means once you master the endoscope, the surgery becomes fast. So we did a study on the learning curve rate. So we compared the results of first 100 endoscopic ear surgery and the last 400, 500 cases we did, and see the difference. It is highly, highly, highly statistically significant. So the learning curve does matter. So what's the number of endoscopic ear surgery that you should know to do to say that you are going to be perfect is number 50. So for first 50 cases, you need to be patient and you need to have lots of patience for doing that. How about the indications of endoscopic ear surgery? I think almost all the surgery that you can do by microscope can be done by endoscope. This is the slide that I got when I was in Singapore. It says in 2015, and it says that endoscopic ear surgery cannot be used for disease involving mastoid. Now, I don't think that's anymore, because I myself am doing lots of mastoidectomy using endoscope. So this built a theory saying that tympanic cavity is the domain of endoscope and mastoid cavity is the domain of microscope, because it makes life easy. So what are the cases that we did? These are the cases. I will show you the videos later on. We started with endoscope examination, then wax removal, keratosis, ventilation tube insertion, and so on, so on, so on, until the middle ear tumor. And the things that I personally still need to learn is cochlear implant using endoscope, petrous apex lesion, vestibular schwannoma, and endoscopic lateral skull base. So what are the, how do I decide that I need a microscope as well, or you need to do a combined endo-micro surgery? For me, I don't use microscope at all for myeloplasty anymore. And nowadays I start doing primary endoscopic ear surgery, which means I always start with the endoscope first, and then I go for a microscope. Then you decide, how do we decide that we need a microscope is because of clinical, and then a high resolution CT scan. You don't want to do endoscopic ear surgery in cases like this, in cases with a facial palsy, in the cases with labyrinthine fistula, dehiscence of semicircular canal, or dehiscence of sinus plate, which can be seen. So in this video, I want to show that why CT scan is needed for the surgery. So is the video playing? I'm not sure.
Yes, we can see you.
Okay, so here you can see that this is, sorry. So here you can see the posterior tympanic membrane is, there's a grade 4 refraction in that. And then you can see the incus is necros, long process ventricular, and you can see the head of the stapes. Obviously, this is a squamous type of a cases, and then you know, if you are not an endoscopic surgeon, you just open the mastoid and do, and so on. So what I want to show in this is, now I'm scraping, and look at here. Look at the attic region. It is perfectly normal. Look at the blood vessels. Look at the mucosa. You won't say that there's a problem in the attic if you don't do CT scan. But then we didn't stop here. Then we start drilling and see what we found. Thick granulation tissues, sticky granulation tissues, and it was completely involving the mastoid. So that's how you know that you required a CT scan. This is the case of a patient who presented with grade 4 facial nerve palsy. You can see the posterior tympanic membrane is all retracted with the granulation tissues and some discharges. So we started endoscopically, and luckily we could finish this whole surgery by endoscope. So we raise a flap, and here the mucosal fold is completely obstructing the anterior and posterior isthmus, and that's the reason why he was getting this problem. And then this is again another fold that you can see. This is the fossa incudis, and then we remove the incus. Remove the incus like that, and then you see the mastoid is totally normal, and there's the dehiscence in the horizontal part of the facial nerve here, and the stapes had partly necros as well. So we use a pick, and then we did the decompression from the whole horizontal segment endoscopically without postural approach. The patient improved, patient is fine, and this has already been case presented. Okay, what are the other areas where we need microscope? See, with a lot of granulation tissue, we are in the antrum. This is actually the combined endo-micro approach. And then you see there's a hole in lateral semicircular canal. See this. With the endoscope, you can just go close. So endoscopic ear surgery, you feel like you are very close to the disease. And then there are lots of granulation. This you need microscope. Another video showing a lateral semicircular canal dehiscent. See here, and the fistula, it moves when you move the stapes. See the closeness that we are working. It seems we are working very close. So how did we started our endoscopic journey in civil service hospital? We started by doing endoscopic examination in outpatient department. Every cases we start showing the patient the pathology, and then we started using the 18 centimeter rigid endoscope 0 degree, so that it made us able to manipulate the hand and to be more acquainted with the endoscope. This was the system that we used. This is a very old system, actually donated by China. And now there's a new system already. We always started the surgery by using a microscope beside us, so that anytime we can change. So do endoscopic ear surgery, but secondary, meaning put an endoscope just to practice first, start with the easy case and all that. And then go for seminars and workshop and training. It helps a lot. Even the Massachusetts and Eye Infirmary will tell you to at least do 2 courses. Here you can see this is the first course that I did in Singapore, and and also the first course for Singapore itself for running the endoscopic ear surgery in 2015. This is the course that we got in Hong Kong. This is the course in Japan, and this is the course which was run by a Canadian professor. And I was lucky enough to even go to House Clinic, where I got to meet Professor House and Professor Brackman. They are 2 very nice people. And also I got to meet Professor Lackner and Professor Kohli from Germany and Austria. And then it was a good thing, because when I was visiting them, they were not even using endoscope for the surgery. So you can see the endoscope is still booming all around the world. And Nepal was also, we were also using the endoscope at the same time when the whole world was using. And then this is very interesting slide I want to show. This is a temporal bone, but 3D photocopy of temporal bone. So nowadays in the workshop, they don't use anymore the cadaver. You can see the middle ear here. For the practice, it's just perfect for the practicing. How about the instrument? I was always asked by so many people, because in your center you have lots of instrument. That's why you are able to do. You have lots of hi-fi system and a high SD system. That's why you are used to do. No. If you have a normal endoscope that you use for FES and normal instrument that you use for myringoplasty, you are good to go. So I want to show what are the stages that we went. Phase 1. See here. Can you see the video? See here the quality of video. That's how we started. See, we insert inside the scope. It's so blurred. The blood touch the endoscope, and you have to remove again, defog again, insert it. It's so frustrating. As I told already, first 50 cases is always frustrating. See this video, still, see the resolution. That's how we started. We started in a very poor resolution, but we had the dedication to start. It was a difficult journey, but it was worth it to do. And then little bit improvement in the quality of video here. As you can see, I'm just trying to show what are the changes that we got. And here, look at the quality. Now we have a 4K quality with ultra high definition, with a 3D effect and all that. Look at the quality. It's so crystal clear. I don't know if the internet is browsing the quality nice, but believe me,
we can see the patient. It's very nice.
Yeah. So that's how we got into different phases. Why I'm showing this slide is, do not make excuse of doing surgery. You should at least start. What are the personal innovations that we did? So during the dissection, I've done a lot of dissection, and with the endoscope, you can see the areas, but you cannot go. So there's always a problem with the instrument. And then me and my father developed an instrument which I now use for the endoscopic ear surgery, and I named and sector, straight needle, curve suction, chisel and bar. So we also made our own bar. And for your information, my father is not a doctor. He's an artist who does metal sculpturing. So let's see a video here. So this is made up of a copper. It can be used as a dissector or elevator. What's the good thing about this is completely malleable. You can put any tip you want. And since it is much made up of copper, you can sterilize. Even coronavirus will not stay there for a long time. So here you can see, you can just bend it like that. This area, there's no normal instrument that can you reach here. The attic editus area, it's very difficult to reach. And here, this is another brown straight needle, but it's not straight because you can bend it in a way you want. So I don't have a video for the suction and the chisel and the bore. I'll show it later on. So what is the theater ergonomics that you need for endoscopic ear surgery? This picture describes about how you should be working in the theater. Monitor should be in the opposite side of the surgeon. And patient, the surgeon stays in the side of the ear that needs to be operated. Sister or nurse stays on the right side. Microscope stays on the opposite side, right to the monitor. So here you can see there's a monitor, there's a microscope. This is me here, and there's a surgeon here, sister here. Here in this picture, you see I'm operating in the right ear. What's the difference is in first picture, my left hand is in the rest of the body of the patient. In second, when you are doing right ear, my left hand is in the air. So this makes you very fatigued while doing surgery. And we made a modification for that. Now I put a trolley or a tray or anything support on that side of the left hand, and it becomes easy. So that's the reason why it is always easy to do left ear first, then the right. This you will learn, and you will share this statement by almost all the endoscopic ear surgeons who do endoscopic ear surgery. They will tell you that left ear, you start left ear first. What are the other modifications? I always do 5 rounds of cold saline flushing before doing a surgery. It's like a norm. Sister, they just, even if I forget to tell them, they will just put 5 rounds before the surgery. Why 5 rounds of cold saline flushing is because to remove all the debris, wax, or clean the surgical site, 1. 2 is to clean the scope tip. Number 3 is to decrease the temperature of canal so that the thermal injury by the scope can be prevented. Armrest, I've already explained the armrest that we do. The paper taping around the ear is something I do personally. I put a lot of paper tape. This is a hypoallergic waterproof paper tape around. There are 2 good things by doing that. One is if it's a female, the hair will not disturb you for the surgery field. Second is it little bit pull the tragus forward, which will widen the canal. Other failed trials we did is I tried cut a suction tube and put inside the canal to make it wide. I start drilling inside the water. For a drill, I put the IV line drip put inside a tube to prevent that. And these were the trials that we're doing and learning and learning and learning. So for me, my personal journey started with the endoscopic ear surgery is on December 2015 or Push 2072, same year when the earthquake happened. That's the same year that I had a first endoscopic ear surgery course. When I meant my first journey, that's the time that I did the sole endoscopic ear surgery without using microscope. So until now, we did 1,120 cases, and almost 700 cases is only for mucosal. So this slide shows what are the cases that we did, and I will show you later on the videos. So you can start by removing the insect or foreign body using endoscope, or you can do a ventilation tube insertion. These are the easiest case to start. And then you can start by using this simple underlay myringoplasty where you don't raise a flap, you just clean the margin and put a cartilage, and then put a perichondrium, and then you're done like that. So there are different techniques for that also, different types like butterfly, modified butterfly, and all that. And this is another myeloplasty video, which shows here the anterior overhang. See this anterior overhang, it makes difficult for you if you do a microscopic ear surgery. There's an adhesion around here in the incrustabular joint. See the magnification and see the way it's being done. So you raise a flap, and then you are done. Another good thing for endoscopy is the anterior perforation. I know for anterior perforation, you have to go for postural approach. Endoscope is just so nice if you want to do anterior perforation. So tympanic flap is raised. So I first put a perichondrium, then raise the perichondrium up, put a cartilage, then put the flap down. Then when you do the cartilage tympanoplasty, you always see there's a gap in front, which doesn't mean always, but most of the time. So put another perichondrium in front, and then cover it with the first perichondrium that was retracted laterally. Sorry, this one. So look at the beauty of endoscope. You can do it in permeatal approach, no need of incision. The uptake rate is very good. And we have we are on a way for publication of this paper as well. How about the anterior flap? Raising the anterior flap in endoscopic ear surgery. So once you are done putting the scope, putting the graft, see, you can just easily raise anteriorly flap. It is much easier if you use endoscope. For microscopic ear surgery, you have to move head here and there, and then sometimes the focus is not there. So it becomes difficult. So that's how the anterior flap can be raised. Another is the cholesteatoma pearl. This patient underwent myeloplasty 2 years back, and now he developed a swelling in external auditory canal. And this is what we call as implantation cholesteatoma or cholesteatoma pearl. You can just remove it endoscopically. It just takes less than 15 minutes for this surgery, and no incision, no scar. Patient is fine, and it is rewarding to do like that. How about the tympanoplasty cases? Here you can see there's a grade 3 retraction. There's a perforation here. The whole tympanic membrane is retracted, so you raise the flap. And there you can see Stapes head. There's a thick glue. Remove all the tissues. Remove the head. And then do some drilling, remove the ossicles. Check the attic adductus area, and then put a graft, and then you're done. Like here in another video, oral polyp. Because I know during my training, these are all that you will advise for post-oral approach and all that. So see endoscopic, it seems like you are very close to the lesion. Just remove it, then take a look around. You see all the margin, everything in one frame. You can even see the ossicles here, and then you can do surgery after that. Oh, sorry. Sorry, the slide just went in the end. Give me a minute.
Ketan, some of our participants are not able to hear. Is there any issue? Sound not audible, sound not audible. I'm getting a ping.
Hello?
Okay.
Shall I continue?
Sure, please.
So another case that you can do endoscopic ear surgery is the revision cases. This is the case which underwent cartilage tympanoplasty in another center. And then here we raise a flap and then remove the cartilage, check the middle ear, the status, any change need to be done, and then put a gel foam, put a cartilage. So what I did is I used the same cartilage again, the one that was previously used, and then put a temporalis fascia graft again as a reinforcement. The patient already has uptake in this result, and the patient is very happy with the surgery. How about the tympanoplasty that requires an attic retraction pocket? Here you can see there's a perforation and there's an attic perforation or retraction pocket as well. Now, when I meant about functional endoscopic ear surgery is you need to see the ventilation pathway and you have to make it patent. So here, this is what Professor Macchioni explained is type 8 attic retraction. However, there's the ossicle is not is necrosed, so we remove the incus and then we put a graft after checking the site. This one is how to do scutoplasty or atticoplasty. So raise a flap, do some dissection or drilling around the attic area, remove the necrosed incus, look at the attic adytus antrum area, remove the stapes head, and then you put a cartilage in the attic area and the scutum is reconstructed. This video is showing on the mastodectomy that you can do with the endoscope. This is a total endoscopic ear surgery where whole mastoid was drilled using an endoscope only. The issue is when you reach more lateral, it gets difficult for endoscope to be placed. So you have to make an arm in a rest position so that it won't be fatigued. See, the cholesterol is removed. See the angled endoscope that you can view the mastoid cavity. But the problem is even if you see the mastoid cavity, you cannot reach here. So you need a special instrument to that. So we developed that instrument. If you don't have an instrument, what will you do? You can use a cotton, put a cotton and scrape with it, which is called as cotton scraping dissection. That's what I term it as that. And then here, I want to show is here, see the sinus plate? Here. This is the bluish one is the sinus plate. I'm rotating the endoscope, so this one, the down is superior and the up is inferior, and this one is posterior and this one is anterior. See the bluish is the sinus plate, and this one is dural plate, is sinus dural anal, and this is already the mastoid. Now, in most of the endoscopic ear surgery cases, you see mastoid as very small compared to the one that when you do as a post-oral, because this is into out technique, you don't do lots of extra dissection that is done in endoscopic part. Another case of retrograde mastodectomy. Here you can see there's a retracted tympanic membrane, lots of cholesteatoma-like discharges. You raise a flap, remove the cholesteatoma flex, drill, suction, use the elevator for dissection. Use curette as much as possible because curette will lessen the tissue damage. You can see there's a cholesteatoma in the lateral semicircular canal. Cholesteatoma at sinus tympani region here. And stapes area, round, facial knob. And see, the eustachian tube opening area is completely blocked with the membrane. So I'm trying to open it. So this is what we call as functional. We're trying to make a ventilation path, ventilation access. This is another case where there is already a cavity here. This was referred from another, some other center. So you do a reconstruction, soft wall reconstruction. So this is how you see in the end. See the optic video in the end. The cavity is almost closed. The soft canal wall is reconstructed. It says endoscopic ear surgery will be much better than myatoplasty, because if you are doing myatoplasty, you are incising the skin and then you get more stenosis. This is the video showing selective epitympanic disc ventilation, type C kind of attic aeration, where the epitympanum is completely separated from mesotympanum by a diaphragm, which is completely closed, and the attic ossicles are gone, and there's an epidermization around it. So what you see here, razor flap, and then see the middle ear area is completely normal. See the beauty of endoscope. Then you do some drilling, you remove all the colostoma flex. You can see up to the mastoid antrum easily here. Then now I am opening the isthmus area. This is the posterior isthmus, and this is the anterior isthmus. See, the head is gone, body is gone, but the ossicles are still mobile. So what we did, we put cartilage over the attic area like that. So soft canal wall reconstruction is done, reinforced with perichondrium, and then you're done. Another case of selective epitympanic disc ventilation. I have like 8 or 9 cases of selective epitympanic disc ventilation syndrome. So you raise a flap. So let me show you the fold that is blocking. Yeah, see, this is the fold, incitomalleolar fold, that is hampering the ventilation pathway from mesotympanum to epitympanum. That's the reason where the patient developed the attic retraction pocket, and now he has a disease of discharging. So what we did is we opened this pocket, this obstruction here. Now this is already open. Now beauty is the ossicles are all intact still. Interostitial joint is all intact, and the disease is removed. And then again we reconstruct the attic area with cartilage and perichondrium. How about the ossiculoplasty? For me, I removed the incus. The removed incus, we sculptured it into the structure that mimics the port, where we put like a cap here. You can see the beauty of the endoscope, see the resolution. And this is already, the mastoid is already drilled. And then we put a cap here, and then we put a cartilage, gel foam, and we put a cartilage here. Okay. Another ossiculoplasty, same like that before. This I have published this in Facebook page. So you do a dissection here, raise a flap, go inside, see the ossicle. You can see the stapes head, but then incus is necroded. So remove the incus, look at the attic area, sculpture the incus again as before, make like a cap, like that, and then put it here. You can even see round window reflex when I move. See, when I move this, made ossicle, it moves. And then you do like that. Hearing improved. Now this video I want to show is how you need to be careful. Now this is again a part of the epitympanic disc ventilation kind of syndrome, because the tympanic membrane is normal, but huge mastoid cavity. Now there's these two structures are ventilating in a different way. The mastoid cavity is ventilating from external auditory canal, and the middle ear was ventilating from eustachian tube. So we raise a flap, and see the middle ear. It's so beautiful. Very nice anatomy. You can appreciate all the structures, anterior isthmus, posterior. You can appreciate this sinus tympani, posterior sinus, sinus subtympanicus. You can even see Jacobson nerve here. You can see hypotympanum, fustis, funiculus, and everything. Then there's this layer that is obstructing the communication between mastoid and the middle ear. See, even if you flush, remove the water, gets suction from here also. Now, what I wanted to show is you need to be very careful when you are dissecting. Now, see, there's already a problem that I created by using a curette. See the problem? The ossicle is already dislocated. So that's how you need to be careful. Just a video showing that the dissection need to be careful sometimes. Now, another video showing the stapes surgery. Well, regarding this surgery, I would like to tell that that it was a way experience to do an endoscopic stapes surgery. What's the benefit in the endoscopic stapes surgery? Less tissue dissection is required than microscopic because you can see it clearly. So you find all the structure that is needed: facial nerve, long process of incus, quadra tympani, and then you cut the stapedial tendon, dislocate joint like that with a pick, then remove the stapes, fracture the stapes, remove it, and put a puncture hole in the posterior foot plate. See the beauty of an endoscope, and then put a Teflon piston, and then put a chorda tympani to prevent, and put a fat, and then you're done. Now the patient was very happy after the surgery. Now the last for the video is this case where we had a huge middle ear mass. The patient came with a complaint of a pain for more than a month, and then we did a CT scan. CT scan, so there's a tumor in the middle ear, and then we decided to do it endoscopically first with the back of a microscope. And I will not tell you what's the pathogenesis, what's the pathology report came. I would like you guys to guess and tell me. Well, we treated it as a glomus, but it's not glomus. So we remove the attic wall. You can see here the mass is embedding the ossicles. It's way up to the floor. You can see here the mass is embedded in the ossicle. I had no option than to dislocate the joint. We were dissecting as the one explained for the glomus is use a cotonoid dissection. It's the same like that. And then here, see the mass up to the epitympanum. The epitympanum area is normal caudalization of the bone can be seen. Facial nerve is very nicely seen here, the horizontal part. That's why endoscopic ear surgeon, they say that facial nerve injury is very less. See, quadra tympani is totally embedded inside the mass. When I look at the floor of the mass, it is whitish. So I got a confidence that it's not glomus. So guys, it's not glomus. Still try to guess what's the report came out of that. And then we dissected around the stapes area. You need to be very, very careful because sometimes the stapes get dislocated or it can get avulsed. Look at the endoscopic magnification and the view and everything. Look at the view. Where is this mass coming from? There's no attachment. Then before removing, we check the additives at antrum, lateral semicircular canal, facial nerve, first genu, second genu, processor cochleariformis. And here you can see this area. This is the tensor fold area. This is the area which you cannot see with microscope. You can see only with the endoscope. Now it seems like the tumor is coming from quadra tympani. And then we try to see, oh, it's not coming from quadra as well. And the tumor is removed. It was more than 1.5 centimeter. Please let me know what do you guess for that. Okay, these are the videos. Now let's come to some of the data that I want to show. What are the cases we did until now? 120 cases of myelingoplasty done, 230 still need to follow up. Our uptake rate is 89%, 71 is including 230 cases. I think this is the uptake of with the average of 6 months to almost a year. Right and left and male and female are same. The difference between the microscope and endoscope, see the difference. See the statistics, what it says. Endoscope has much better result than a microscope. These are the publications that we did with Professor Ajit Nepal, Dr. Arun Kesi, and Dr. Nirmala. Our study. Another study we did is on the long-term uptake of the fascia and cartilage. This is the reason that I don't use fascia anymore, because in the first 3 years, the difference was not significant. But after 5 years, see, fascia is not working anymore. It has much more failure than the cartilage, so I don't use fascia as much as possible. About the site, anterior and posterior, see, endoscopic has such a great high uptake rate than the microscopic for anterior perforation. Another article on the anterior perforation data, this differentiate between the single and double endoscopic anterior perforation. About the data on squamous cases, we did around 82. That's only for endoscopic ear surgery only. But besides that, we have done a lot using microscope or microscope and endoscope like that. So male and female and right and left is like 50-50%. Attic area, most of them around 50% there's a destroyed and 50% is intact. And then this is the 50% as cholesteatoma, 50% as granulation, and there's a 50% as perforations and all that. This slide shows what are the common ossicular disruption that we found is long and lenticular process of incus necrode. And the graft, 95% I use is cartilage with perichondrium, and then or with temporalized fascia. So this slide is very important because this is what I wanted to show. 67 to 70% I do either drill or I curate the attic area or posterior superior area. So 14% I don't need to do anything. SCW, meaning soft canal wall reconstruction, was done in around 43%. What are the kind of type tympanoplasty we did? Type 3 is the most common we do, around 60%. And what's the result? So the result, this is the early uptake result of 6 months. We had 96% uptake in endoscopic ear surgery until now. But then 24 patients are still not following up. And this is very early for me to say. We're still waiting for to have a long-term result. Now, what are the 10 problems that are encountered in endoscopic ear surgery and how to tackle them? This is what I learned from my experience or my evidence-based data. It is a one-hand surgery, so it becomes difficult. There are centers which develop a holder for that, but Massachusetts Eye and Ear Infirmary tells you not to do that. And then learning curve, I already told you 50 cases, first 50 cases has a learning curve. Crowding of instrument, yes, there's a crowding of instrument when you do the surgery, but you need to have a patient, you will learn how to cope with that. And then now the recent concession is you need 3 millimeter wide angle view scope, 14 centimeter in length. And then you need 0 degree and 45 degree. Heat injury caused by the scope can be tackled by decreasing the illumination to 50%, using constant defogging, using constant suctioning and flushing. They decrease the temperature. That's not the issue anymore. All the literatures are now negating on the heat injury. How about the drilling issues? How do we drill? So if the canal is narrow, make it wide. Always use curate first because it prevents the skin laceration. You'll know it if you do it. Using a hook in a canal that was used to widen the canal. Chisel and hammer can be used for dissection. This is what the Japanese people still use. It is so nice to see they do dissection using chisel and hammer. Ultrasonic bone curate, piezoelectrical device are the recent devices that are available in the market. Now the piezo is the like of piezo is decreasing because it's so slow doing piezoelectric device. I'll show the video later. Scriptal drill is another beautiful device that you can have. We also have a scriptal drill, but we don't use it much because the drill bore is so expensive. So how to drill? In the drilling section, the number one is you need to have patience. Do not rush. So my personal technique is do a slow intermittent drilling. Like you make a speed of 50 to 75%. So you drill, you stop, then you flush, then you suction. Then you drill, then you stop, then you flush, then you suction. And once the bone is thin out, you use a curette to remove it. So you need to have a lot of patience. It seems impatient to do, but then it's completely worth it. How about the difficult areas to reach, like retrotympanum, sinus tympani, hypotympanum, and all that? Yes, we developed an instrument for that also. If you don't have instrument, never mind. You can still use a cotton, put a cotton and scrape using a cotton, which we call it as cotton and scraping dissection technique. How about the bleeding? Well, this is most annoying one of the problem in endoscopic ear surgery. If you are doing in local anesthesia, for me, what I do is I give a local anesthesia first, and then I go for a scrub, and then I come back, I drape and do surgery. By that time, local anesthesia is perfectly working fine. I just put a local anesthesia using a headlight. I don't use a microscope or I don't use endoscope for giving a local anesthesia. If you are doing a general anesthesia, better if you have a hypotensive anesthesia, you can tell anesthetist to do that. But if you're doing local anesthesia, I advise you not to do it. The pressure is very high. You can use a head elevation, which is same as that in sinus surgery, which decreases the congestion. And do not be stingy to use the cotton soaked with adrenaline. 5-minute rule is given by Massachusetts Eye and Ear Infirmary, where you wait for 5 minutes before the adrenaline works. Bipolar cautery, yes, you can use that. And recent advances is they're making a cautery that is designed only for endoscopic ear surgery. The number 10 problem is reconstruction. So I do most of the reconstruction using triangle cartilage and perichondrium, but when you have not enough amount of tissue, use fascia for that. So this is the new in town. You have an ultrasonic bone curette. You use a low frequency sound. There's a new Medtronic drill where only the tip moves. This is what we need. This is the system for Sonopet. Sonopet is a name given by Stryker for ultrasonic bone curette. And this is the piezo. See, this is Professor Macchioni drilling that during our conference work. He is drilling around the geniculate ganglion area. But it's so slow using piezo. Sometimes your patient might go away. This is the latest is the robotic endoscopic ear surgery. This is what the Japanese are doing now. So my personal 15 tips for endoscopic ear surgery is use rigid endoscopes, 18 centimeter, sinoscope 4 millimeter. It works perfectly fine. Start with the adult patient using a wide canal. You can use a canal endoscopic score now, which is given by Professor Eich. And then you can start with using a wax removal or foreign body removal or ventilation tube. Then you always start the endoscope with a microscope backup and try to learn anatomy in every case as much as possible. Start the myringoplasty with the simple cases like wide canal with a posterior perforation, small perforation. And then always start with the left ear to encourage yourself, because you will know with the practice why most of the surgeon will tell you to start with the left ear. Modification for right ear, we use a trolley. Now there's a robotic arm in Japan. And then you can widen the canal. You protect by using cotton, paper, or foil. You can protect a flap. Drill posterior superior area first. Avoid drilling below the exit of chorda, meaning why? Because below that, the facial nerve can be damaged. Cholesteatoma is usually not found below that, and reconstruction can be difficult. Extra instrument, do you need? No. To start, you don't need extra instrument at all. You can start with the sinus instrument. And for us, because our country is developing country, it holds a very bright future in the health chem section. Here, you can use this tool for educate a patient who doesn't have education about the health condition. You can use as a tool to teaching and learning activities in a health center, in a remote health center. You can use a telemedicine with this, and so much of the advantages. Finally, my tip is endoscope is not a substitute for microscope. Do not be endoscopic or microscopic ear surgeon, and do no harm to patient. This is again another 10 commandment given by Massachusetts Eye Infirmary. I just want to state here is it says do not use holder in their part. It also says use left first. And then it says keep practicing, and expect for setbacks, because it is a challenging and frustrating in first few cases. As I told, first 50 cases is challenging, but then once you reach in top of the hill, you will pick up. So you can meet me at my channel in YouTube. I think this will be uploaded in international working group as well. We have all the members are allowed to, is required to develop a channel. This I've been developing because YouTube is another teacher. For us, I learn a lot from YouTube. Besides the real teacher that I learned, and then this is my Facebook page. You can meet me here as well. And thanks so much for your time. Let's hope the corona goes away soon. And before ending, I would like to acknowledge Dr. Oren Casey, because he was with me with this journey. Unfortunately, it's unfortunate for me, but it's fortunate for the place that he went. And also, I would like to acknowledge Professor Ajit Nepal. He has been always my backbone, our backbone of civil service hospital. And then I would like to acknowledge Dr. Ravindra Pradhananga. He has always been a guy who always helped me a lot whenever I have a problem in otology. I think he's one of the best otologists in our country. And finally, there's no financial disclosure and no conflict of interest in this presentation. Thank you so much, and thank you so much for your time.
Thank you, Dr. Deepesh. Thank you so much for excellent presentation. We had more than 180 participants who registered for this talk. And I think it was such a nice, I think everybody, when the corona is done, everybody wants to go to our operation theater and do a left-sided endoscopic ear surgery. And so we have some questions for you. Okay, let's start with this. There is a question from Dr. Rishi Bhatta is saying that in case of a normal attic and editus and granulation tissue in the antrum, what do you think may be the pathogenesis of the disease?
Okay, so the pathogenesis is still
Normal
controversial.
attic.
Yeah.
Okay.
So should I answer now?
So second question is, how do you infiltrate local anesthesia? This is from Dr. Urmila. How do you infiltrate your local anesthesia?
Okay. So regarding the first question, the pathogenesis of all the condition in chronic otitis media is still controversial. If you go to a literature, you'll find a lot of theories, and selective epitympanic dysventilation is also one of the theories that has been postulated. Here you can see in one of our video, a patient presented with a facial nerve palsy that I showed before. Actually, there was granulation tissue around in posterior superior area. And then it was, again, the ventilation pathway that was obstructed, causing a granulation to form. And granulation tissue, it at times can be a defense mechanism or a reactionary process of our body where the tissue get inflamed and the granulations are formed. For me, what the concept was is, what we were doing is we use a postural approach. We go a mastoid and we do a surgery first, mastodectomy, and then you do a endoscopic, you do a middle ear surgery. That's what we all are doing now. The concept has changed now. Why? Because once you do a mastodectomy, you are already tired. Now you are doing a tympanic cavity. You know, I remember when I was a resident, we do a mastodectomy, and then when you are about to do the stapes area and middle ear area, you are already tired to do that. No, the concept has changed. Now the disease is coming from the middle ear, and then it is going to the mastoid. Mastoid is basically just the innocent culprit. The diseases are coming from middle ear. So middle ear should be addressed first, and then the mastoid. That will prevent unnecessary dissection, unnecessary incision, unnecessary exposure, and all that. So for me, why granulation is formed is because of the infections or inflammation. It's a reactionary form that is formed. And again, another problem is with the granulation is, you know, it's much easier if you have a cholecystoma than a granulation to do a surgery.
Okay. So
and the next question is about giving local anesthesia in external auditory canal. It is the same like what you do in microscopic ear surgery. At least, in fact, In fact, what I notice is the amount of local anesthesia is much lesser than the microscopic that you do.
Okay, so there is another question. When do you do canaloplasty? Do you routinely do canaloplasty or not?
Okay, so there are two ways to do for this in endoscopic ear surgery. Canaloplasty, if you have enough area, if you do only the aticoplasty, or if your cartilage is enough, then you put cartilage at the attic area to close or seal to make cavity as much as less as possible.
Okay.
Canal wall up and canal wall down surgery, as we all know about this, there's always controversy on that. You know, the first came canal wall down and then came canal wall up. Now there's a new trend in endoscopic where they use a modified canal wall down technique. So this is a new thing, and then I think all the concept and all the way that we used to operate in ear is changing a lot. Even the Westerners are now they are modified. So you cannot compare, or you cannot say that microscopic, if you are a very well microscopic ear surgeon, you are perfect in that, and then you start doing endoscope, you will have very difficult time, because the laws that you use in microscope doesn't apply in endoscope.
Okay.
So I don't know if I answer or not.
Yeah.
So canaloplasty, you know, it will take a long time for me to explain, but you know, the concept of canaloplasty is if you can close the cavity, you close. If you cannot close the cavity, you make a two separate cavity. One cavity that covers the tympanic cavity that is ventilated by eustachian tube. Another cavity you make open for the ventilation that is given by external auditory canal. So you get the point.
Yeah.
So that's the concept of the ventilation or the functional endoscopic ear surgery. You need to give a function to that.
Okay. So was that a tumor that you are talking about, a schwannoma from a tympanic plexus? It is answered by Irina.
Oh, okay. So that's not the right answer. I would like some more guesses to be done. What's the tumor?
We have only 6 minutes to guess more because we are running out of time.
Okay.
So there is another question. Why you need a microscope in lateral canal fistula? Is it in need of two hands or requiring delicate dissection that you have to do?
Yes. There are 2-3 factors that you need a microscope. First is if you know there's already mastoid fistula with a CT scan, you know by clinically, then you are wasting time because you need to dissect a lot of tissue. One. Second, with preoperatively, you will already know that this is going to bleed. So it's again waste of time. You need a microscope for that. Okay. And third, as I told, we are not endoscope or microscope surgeon. We are ear surgeon. So to save the time of the surgery, to save the complications, it is much easier if you can work with a two hand in the mastoid fistula and the defect area. That's why I tell to use a microscope.
So what about fogging, repeated fogging?
So okay, so there's so I want to add one more thing is, so start with endoscope first. The concept is changed. I told you already, start with endoscope, do a primary endoscopic ear surgery and take an assistant of microscope as much as possible. Like that. And about the fogging, there's an issue on that fogging. We use a Savlon for that. And then you have to rest in the canal, the scope. With practice, you will learn how to not fog much.
It is same like sinus surgery.
Yes, same like sinus surgery.
Okay. So there's a question that you always love to use a cartilage material. You don't use a isolated or say, only the fascia or okay. So
this is already proved by my own article.
Yeah, I also love doing only the cartilage. So
because the fascia long-term uptake is not good, it's decreasing. Now my 5-year follow-up, the uptake is only 66. If I wait for 5 more years, in 10 years, maybe all patients will come back.
Yeah, so I think it was such a nice this thing. Okay, one more question. How much concentration of adrenaline you use? Is there any risks with high concentration of adrenaline to blood supply of facial nerve?
No. We didn't find any complication with that.
So
So
what is the
for
procedure?
what I do is, I tell the sister to make 10 cottonoid with the different sizes and to put 1:100,000 adrenaline soaked in that.
Okay, okay, okay. Mhm. If you find a disease going to an inaccessible area like tip cells during mastoid, do you switch to microscope or give post-oral incision and proceed with the endoscope?
Okay, so this is very nice because, as much as possible, as much as I can, I always go for endoscopic. I've already shown you the mastoid tip. I have lots of other videos also. We're doing the mastectomy, whole mastectomy using endoscope, but it's frustrating because you are already in the tip, in the lateral area. There's no
Yeah.
rest for the scope.
Mhm.
So as much as possible, go for endoscope. But then, if you think there will be harm, or if you think there will be a residual part or a residual disease is going to leave, then you go for microscope. So I want to add one more thing on this. So there were a concept of secondary endoscopic ear surgery where they did a microscope first and look around in the area where the disease was found with the endoscope. That was area before the rise of endoscopic ear surgery as sole. And there they found what's the percentage of the cholesteatoma they found was 17 to 70%. See what we are doing. 70% you leave cholesteatoma if you do only microscopic ear surgery. That's the way big. So even if you cannot at least put an endoscope and see the areas that you cannot see in microscope, like sinus tympani, retrotympanum, and all that. And second study, what are the recurrence rate that you find when using endoscope? Is if you use endoscope, it decreases to 0 to 17%. See the beauty of endoscope. So if you don't use endoscope, it can have 70% residual. If you use endoscope, it can be 0 to 17. Still, you can have that, but then it decreases
less. Yeah, and the rest, all the message were thanking you by all for such an excellent presentation. I think everybody enjoyed today. So so I like to thank you, Dr. Dipesh, for such a wonderful presentation, and I'd like to thank Sitla for doing all this and making and allowing us to share this platform. So I'd like to thank everybody who joined us, and wish you to see you all next Saturday.
Thank you, everyone.